एक मिनट, एक मिनट, एक मिनट, एक मिनट। किसी को प्रमोट एज अ पैनल में नहीं कर सकते, कर पा रहे हैं, क्या करूं मैं? जो पैनल में जो ये अटेंडी जो है ना, उसको पैनल में प्रमोट नहीं हो पा रहे हैं वो लोग।
तो समझ नहीं आ रहा आपकी आवाज का, पैनल में प्रमोट नहीं कर पाए बोले तो
आ गया, चलो
मैं करूं पैनलिस्ट में,
मतलब जिसको पैनल में आना है ना उसको लॉग इन करना पड़ रहा है, ऐसा है।
अच्छा 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 अच्छा,
वो आएगी पैनल में,
ज्वाइन करके देखो ना।
मैं करता हूँ, एक मिनट, मैं होटल में।
हेलो,
यस मैडम, गुड इवनिंग। हेलो, मैडम एम आई ऑडिबल? हेलो भावना मैडम?
for Association of Breast Surgeons of India. So I told him to join in between whenever he is free. So this is regarding Dr. DG Vijay. He is the coordinator for this webinar also. Next slide, please.
Ma'am, the slide is not moving. Can I stop sharing and can we move directly to the presentation?
Yeah, please,
of Dr.
please. You can go. No problem. I think everyone knows me here. So
Yeah,
let us
I'm,
Dr. Lira's.
I'm stop sharing the slide. So, ma'am, now you can, Lira, ma'am, you can share your screen.
Okay.
It is visible now. Lira's slide is visible.
Yeah.
Okay.
Okay.
I request everyone to mute themselves because actually we have do we have a format that only speaker is allowed to speak? Ketan bhai.
Yes, ma'am. This is a very updated means version. So now, without our permission, no one can speak in between.
Okay,
So if anyone wanted to,
but so
anyone wanted to speak, then they have to raise their hands, and we can allow them to talk.
but that is after the completion of lecture, and we all panelists can speak in between. So that I think I will mute myself. Is it?
Yes. Those who are promoted to panelists, they can
Mute
talk. They
themselves.
can
Okay.
on the video as well.
Okay, no problem. Okay, I will hand over to Lira. Over to you, Lira.
So good evening all. So I'll be talking about a practical approach to handling of breast cancer specimens. The outline of my talk I've divided into four parts. Firstly, current challenges in histopathology, starting from specimen collection and handling to lab processes. Second part would be practical points of grossing breast cancer specimens and best practices to be followed for precise reporting. Thirdly, handling of surgical resection specimens after neoadjuvant chemotherapy. And at the end, little bit about ER/PR and HER2 testing. There are challenges specific to histopathology. Histopathology diagnosis is image-based, and unlike radiology, there are several steps in processing a specimen prior to image viewing. The specimen is valuable and cannot be procured a second time. Many of these steps are manual, skill-intensive, requiring human intervention. Processing directly impacts downstreaming tests, including IHC, molecular testing, and NGS. These are some of the common problems associated with fixation. This is an example of a larger specimen smashed or squeezed in a small container. This is an example of inadequate volume of formalin. This is a Ziploc bag wherein the formalin has leaked out. And lastly, this is an example of an appropriate leak-proof container with adequate volume of formalin. Some examples of specimen sent in normal saline. This is a specimen sent without formalin in a plastic bag. Now, lab testing can be divided into three phases: pre-analytical, analytical, and post-analytical. Pre-analysis comprises of specimen collection, transport, processing, and storage. Analysis, that is testing, and post-analysis, which includes result transmission, interpretation, follow-up, and retesting. Now, errors which are made in the pre-analytical phase may influence the quality of the final results and thus compromise the diagnosis and the treatment of the disease. Hence, no result is better than a bad result. And all you know is accurate result is the best of all. Now, pre-analytical phase can be divided into four subphases, that is preparation prior to sampling, handling of the specimen, transport of the specimen, and preparation prior to reporting of the specimen. Specimen handling in histopath is a crucial aspect to ensure integrity and quality of the specimens for accurate diagnosis. It can be divided into basically broad categories, that is specimen collection and handling, and second is lab processes. I'll be discussing each of these in detail. Now let us go to specimen collection and handling. First is patient identification and proper labeling. One should label the specimens immediately after collecting and before leaving the patient. Each specimen should be properly identified and all the details should be recorded as soon as possible. This is an example wherein the details of the name, the hospital ID number, patient has two specimens, the first and the second container, both are labeled neatly. Next is the completion of requisition form, wherein all details of the patient, specimen name, type of the specimen, site, pertinent clinical history, the procedure time, which includes warm ischemia time, the cold ischemia time, and the transport time, all ultimately adding up to the total fixation time. So all the biopsies should receive minimum 6 hours of 10% neutral buffered formalin fixation. Ideally, as per ASCO-CAP guidelines, fixation time is 6 hours to 72 hours for ER, PR, HER2. Nothing less, nothing more. Little bit about what is warm ischemia time. So it is a time measured from the interruption of blood supply to the tumor by the surgeon to the excision of the specimen. And cold ischemia time is time from the excision of the specimen from the surgical field to the time the tissue is placed in a fixative. And ideally, that should be less than 1 hour. And transport time is the time the tissue specimen was collected from the operating theater and it is received in the laboratory for processing. So these are the different types of times we should note in the form. Next is accessioning. So each specimen container received must be compared for at least two patient specific identifiers. Patient's name, any health record number, date of birth or the age of the patient. And in addition to that, one should check the number of specimen containers, the type of the specimen submitted, clinical history, the referring doctor who has sent, and the collection data, that is the fixation type. All these are checked by the lab personnel. Coming to some of the recommendations for tissue collection and handling. One should avoid using cautery because that causes heat injury or thermal injury, and that may interfere with diagnosis. Similarly, crush injury and drying injury can also interfere with the diagnosis. Let me give you some example. Now, this is a benign ductule and these are the lobules of the breast. And what I have highlighted is with the arrows is the cautery injury or the heat injury, which is because of the cautery used. This should be avoided because that will interfere with the diagnosis. Similarly, tissue should be removed gently to avoid trauma which is caused due to tearing or crushing. And sometimes because of the crushing, it is difficult to differentiate tumor cells from the inflammatory cells or the lymphocytes. Third example, because if you keep the tissue in the dry state, then that will also affect in reporting. So specimen should not be allowed to dry prior to fixation. Also, the specimen should be handled gently because fragile specimens would get damaged if not handled with care. Now coming to fixative. What is an ideal fixative? That which reacts rapidly and completely with the tissue and fixing all the constituents and which penetrates deeply. So 10% neutral buffer formalin is the ideal fixative. pH ideal is 6.8 to 7.2. Volume ideal is 10 times the volume of the tissue. Minimum 10 to 20 times of the volume of the tissue is the amount of the fixative that should be used. Cold ischemia time, as I said, should be less than 1 hour. And the duration of fixation, that also I have said, 6 hours to 72 hours. I've highlighted the formula of the 10% neutral buffer formalin. So commercially, what is available is 40% solution. And in that, by adding 900 ml of water to 100 ml of 40% solution, we get 10% formalin solution. This is again buffered with sodium dihydrogen phosphate and disodium hydrogen phosphate to form this 10% neutral buffer formalin. So once you prepare adding these buffers, you get 10% neutral buffer formalin. We record the pH of the formalin, which can be done either by a strip test or by pH meter electronically. And ideal is 6.8 to 7.2. And if the pH is acidic, then it will formalin will react with hemoglobin and will cause formalin pigments, which will also interfere with the reporting. So pH is also important. Next is volume of the fixative. An adequate volume of fixative is used in a container of appropriate size. This avoids distortion of the fresh specimens and ensures good quality fixation. As I said earlier, 10 times the volume of fixative, 10 times the volume of the tissue should be the fixative. One should not stuff into small containers and transfer to a suitable container after slicing or cutting open. Next is large specimen should be rapidly transported to the lab to allow grossing. And it should be serially sliced with cotton in between, which will help in proper fixation. If the fixation is delayed, it will cause degeneration of the tissue as the specimen is deprived of the blood supply. So this is an example wherein I'm just seeing the ghost outline of cells and I'm not able to appreciate the nuclear details. So this is what happens if fixation is delayed. It results in autolysis. And there is also a problem if it is poorly fixed and poorly processed. Then this is an example wherein this is a paraffin block where the tissue is poorly fixed and processed. In this A part of the circle, the outer area is well fixed. So if you take sections, this area has got the formalin, so the details are well preserved, whereas this area has not received the formalin, and that hinders in especially in ER/PR and HER2 testing. Uneven staining due to zonal fixation. That is a big problem. So fixation ultimately affects the downstream processes like IHC, ER/PR, HER2 testing, molecular testing, and so on and so forth. So it's a very crucial step. This is another example. So if you use good quality fixative, that is 10% neutral buffer formalin, you maintain the fixation time, that is between 6 hours to 72 hours. The pH is maintained between 6.8% to 7.2. So all these things are maintained, then you will get good fixation. And if a well-fixed tissue, the ER/PR results are good. But if the fixation is not good or it's a poorly processed, that those areas will not take up the ERPR or HER2 staining. So uneven fixation, zonal fixation will result in uneven staining, and that will affect the ERPR reporting. So if it is a 90 or 100% ER positive case, will give rise to maybe 40% staining because of the fixation or pre-analytical issues. Little bit about the frozen sections. This is the machine which we have in our lab, and the specimen should be sent fresh or in normal saline, but never in formalin. I have discussed the earlier steps of specimen collection and handling, and let us go to the lab processes, which includes fixation, processing, embedding, microtomy, staining, and cover slipping. Now, these are the different processes from the tissues after grossing. They are placed in the label cassettes, tissue processing in the processor, embedding, microtomy, and staining. So I'll walk you through the different machines in our lab. This is an automated tissue processor, which has different changes of the alcohol, xylene, and paraffin. And mind you, the tissue passes through at least 13 hours of processing before it results into the formation of a paraffin block. So once the 13 hours of processing is done with different changes of xylene, alcohol, and paraffin, we get these blocks. They are ready for embedding. This is the paraffin dispenser, this is slide warmer plate, and the cooling plate. So after embedding of the tissue, we get this paraffin block. Now, the quality of the wax is also important, because if the wax is of good quality, the blocks are easily cut and the tissue is preserved for further ancillary tests. But if the quality is not good, that will result in difficulty in cutting of these blocks. The tumor tissue is depleted, and the results, later on the results will affect the results. Also, if the blocks are filled with lot of wax, that will also hinder that will also damage the tissue during microtomy. So this is the microtome machine, tissue flotation bath, and the technician takes the sections. This is how the sections are laid from the blocks. And once you get the sections on the slide, this is the H&E auto stainer which we have, and it will stain the slides. This is just a special stains, the cyto spin centrifuge, the IHC basically for antigen retrieval, PT-link module, and IHC auto stainer. So this is what we have. So once the reporting of the biopsy is done, they are filed in the slide filing boxes here, and the specimen basically goes back to the specimen filing room, wherein we have different cabinets for different days. So this is the 5th day, this is the 6th day. All these specimens are filed back according to days. Now, coming to second part of my talk, I'll be talking about the practical points of grossing breast cancer specimen and best practices to be followed for precise reporting. It includes the specimen identification, orientation, inking the margins, slicing of the specimen, fixation of the specimen, description and dimension, and taking relevant sections. So grossing is basically a shared responsibility of both the surgeon and the pathologist. There are few prerequisites. I've already talked about the specimen transport, some acquisition, orientation, talking a bit about fresh versus fixed. A single or a cruciate pair of incision into the lesion is important, thus preserving the integrity of the margins. Now, the benefit of the rapid fixation, that is preservation of hormone, that is ER, PR, HER2, is way more compared to preserving the intactness of the specimen. So it is better to put an incision, a single or a cruciate pair of incisions, if you are sending the specimen maybe out of the hospital to another lab outside. And it should always be made from the posterior aspect. So this is an example of a cruciate shaped incision which can be made by the surgeon, which will help in rapid penetration of the formalin, because the formalin takes around, it penetrates at the rate of 4 millimeter in 24 hours. So this step is very important. Specimen can be transported either in a spacious container or freshly in a plastic Ziploc bag. And 3 suture orientation is generally done. Then the rule is short superior, long lateral, and medium suture on the medial aspect. So this is just an example of the requisition form, how it is filled up. And this basically orienting the suture short superior, long lateral, and medium suture medially. Anteriorly, there is a skin. So that will allow the reorientation by the pathologist. And if the pathologist needs to revise, then they can revise from the areas. Accurately measuring the lump is important, especially for breast prosthesis in oncoplasty and cosmetic breast surgery. As I said earlier, 10% neutral buffer formalin, no less than 6 hours and not more than 72 hours is important. Under fixation, mind you, will lead to false negative ER results, and over fixation leads to false positive HER2 results. So that has to be kept in mind. Now coming to inking a lumpectomy specimen. A gross cutting is equal to surgical cutting, and hence we should ink the external surface. And one can use washproof ink, that is Dhobi ink or India ink. And one should not dab it forcibly, because that will result in seepage of the ink into the specimen. So this is an example using multicolor inking. You can remember the code, that is the sky is blue, grass is green, medial aspect either brown, laterally it is yellow, superficially red, and deep is black. So this is an example wherein green ink is used and blue ink is used for the margins over here. Next is slicing of the specimen is very important. Now let me show you some of the examples. This is basically a sagittal section wherein you slice the specimen as you do it. This is called bread loaf technique, or slicing the specimen medial to laterally as you slice the bread, loaf of bread. This is one technique. So that can be used. This is schematic diagram showing the same slicing of the breast lump from medial to lateral. Another way is you slice it in this fashion. This is usually used for microdocectomies or ductal lesions. And third is a cruciate slicing, wherein this is the tumor and these are the margins, superior, medial, inferior, and lateral. Now coming to the tumor size and the margins. So this is the specimen, this is the tumor, this is the margin, and you measure the distance of the tumor from the margin. The tumor size is basically size of the invasive cancer, and it is an important prognostic factor. Single greatest dimension of the invasive carcinoma is used to determine the T stage. Now, the best size is basically when you get all the information, the imaging details, the gross examination, and the microscopic evaluation. So that is where we always require the help of a surgeon, that they should always provide us with the radiological details. Because at times, the tumor carcinoma blends in with the adjacent fibrous tissue. It becomes difficult to pick up at times if the tumor is very small. These are a few of the examples wherein how do we determine the size of the invasive carcinoma. This is the main tumor. This is the T size, and adjacent there is DCIS. So the invasive carcinoma is taken into consideration for the exact tumor size, and DCIS is neglected. This is the core needle biopsy and the excision specimen. So you don't have, you're not supposed to add up the biopsy and the lumpectomy later on. This is another example wherein this is another tumor and there are multiple invasive tumors. So if the distance between the two tumors is less than 5 millimeter, then they should be counted together, that is from one end of this side to one end of this side. If the distance between the two tumors is more than 5 millimeter, then they should be counted as two separate tumors. This is how we do the. Now, if we take a section from the intervening area and there is no tumor, then they are considered as multifocal disease. So multifocal disease is basically the presence of two or more foci within the same single quadrant of the same breast, and they are within 5 centimeter of each other. Whereas multicentric disease is defined as two or more tumors within different quadrants of the same breast, and they are separated from each other by more than 5 centimeter. And if the intervening area shows tumor, then the final T stage would be from this end to this end. Few more examples as to how we try to measure the invasive component. Now, in this stage, it is very clear that this is the invasive tumor. This is a T size. This is the whole width of the tumor, whole tumor measurement, but the invasive tumor is this much, and DCIS, as I said earlier, is not counted. Again here, bit of DCIS not counted. So invasive tumor is only this much. This is the whole tumor. If the distance between the two tumors is more than 5 millimeter, this much is only the T size. And when you have multiple foci of DCIS with multiple foci of invasive tumor, then this is this much, the entire thing is counted as the invasive tumor. Now coming to the concept of extensive intraduct component. So it's basically presence of intraduct carcinoma more than 25% of the invasive infiltrating tumor, or if the invasive intraductal carcinoma is present in the adjacent normal breast and comprising of more than 25%. So I'll show you examples of the same. This is an example wherein this is the entire tumor, and predominantly it is almost, I would say 40-50% is DCIS. These are different foci of DCIS. So this is a case of invasive carcinoma with extensive intraductal component. Another scenario is this is the invasive tumor, and the adjacent normal breast shows a lot of DCIS, almost more than 25% of it. So this is also extensive intraductal component. Now schematic diagram, this is tumor and extensive DCIS. Another case, multiple foci of invasive tumor with extensive DCIS. This does not come under extensive DCIS, and this is also not considered because this tumor and far foci are there, but not more than 25. So these two are examples of extensive intraductal component. Now, what is the main importance of this is if we should be able to identify this because they are associated with local recurrences in breast conserving tumors. Coming to margins of lumpectomy. So it's always best to remember this mnemonic, which I always do, of SIMLAB, that is superior, inferior, medial, lateral, anterior, and posterior. So you will not forget any of the margins. So this is the tumor, and if this is the very close to its shave margin, and this is the radial margin. Microscopically, this is a tumor going into the muscle, and this is the radial margin. So a positive margin is the one wherein the tumor has reached to the inked margin, and negative wherein there is normal tissue around and the edge from the tumor. So these are the sections which we take in lumpectomy: tumor sections, the lymph node sections, and the different margins, and skin if present. That is also taken. Now coming to grossing of the mastectomy specimens, one should examine the skin, presence of scars, orange, puckering, ulceration. Nipple areola should be examined for the retraction, inversion, and ulceration. Need not discuss the types of mastectomies to the surgeons, but basically they are divided into simple, skin sparing, the nipple sparing, modified radical, and radical. We serially slice the specimen at 1 centimeter interval and take sections. Now showing you some of the examples of how do we assess skin involvement. Now this is an example wherein there is Paget's disease of nipple and there is associated invasive carcinoma. So this is not skin involvement. This is another scenario wherein there is invasive carcinoma which is invading the dermis and the epidermis, but there is no skin ulceration. So this is also not in skin involvement. Now these are the C, D, and E are the scenarios wherein examples of skin involvement, where there is actual skin ulceration. Okay, this is example when this tumor and then there is a satellite nodule. And this is an example when there is dermal lymphatic invasions, orange or orange skin appearance. This is skin involvement. Coming to the axillary lymph node dissection, if the lymph nodes are small, we embed it entirely. If it is a big lymph node, then ideally it should be bread loafed as we do the tumor sections and submit it entirely. So one should assess the tumor size of the metastatic deposit, the extranodal extension, and if there is any cancerous nodule in the axillary fat, that is also should be mentioned. And the sections of mastectomies are basically sections of the tumor over here, the nipple areola section, adjacent breast, the tumor with the base, the skin section if needed, lymph nodes at the end. Now, coming to the third part is handling of surgical resection specimens after neoadjuvant chemotherapy. From the surgeon, we require, apart from clinical data, a radiological report also. And this is very important in neoadjuvant chemotherapy cases, especially. It would help us if we have a core biopsy report with us, axillary lymph node status, the chemotherapy cycles, the size and location of the tumor prior and after chemotherapy, and the clinical and radiological impression of the treatment response. So all these things, data actually help us a lot. Especially it is imperative to have a mammography report, at least a radiology report, if to know whether the lesion was single or it was multiple to start with. Because the tumor bed after chemotherapy it becomes like a fibrotic area with few fibrotic streaks, and at times it just vanishes. So it becomes very difficult for us to pick up. And residual tumor is basically like fleshy nodule. This is an example of tumor, pre-chemotherapy, and after chemotherapy, there is just rubbery fibrous tissue left, and this is a fleshy nodule within the tumor bed. So this well-defined tumor actually almost vanishes with chemotherapy at times. And placement of the clip prior to treatment is very helpful for us. So once we identify the clip, we know that we are sampling the tumor bed. Similarly, for wide local excisions, I need not go into detail. Coming to pathological response, PCR is defined as complete absence of invasive carcinoma in the breast and no residual metastatic carcinoma in the lymph nodes. And in locally advanced breast cancers, PCR is seen in around 5 to 30% of the cases. And HER2 new positive and triple negative breast cancer show good response. And there are different classifications. I need not go in detail. Now, this is neoadjuvant chemotherapy to a tumor either will give complete response or partial response. So in complete response, you want, there will be no residual disease. In partial response, either you will have a concentric shrinkage, concentric pattern, or you can have a scatter pattern. The cells, residual tumor cells will be there scattered throughout in the tumor bed. So this is how the chemotherapy responds in the breast. So this is a busy slide, but I just want you to concentrate on this area wherein one should do systematic sampling of the post-chemotherapy breast specimen, serially slice the specimen, and should be sections should be taken accordingly. And this is an example of the different types of patterns which I have explained, the scatter pattern and the concentric pattern. And what can be the better way of mapping or reporting the residual breast cancer? That is also a question. So there are different guidelines. One is the ICCR way of reporting. One is the AJCC staging, and another is the residual cancer burden system. So basically, in the AJCC, the single largest contiguous focus is considered as the T stage, and the fibrosis is not included into it. In the residual cancer burden, one needs to include the tumor bed dimension, the cellularity of the invasive tumor, the size of the largest metastatic deposit, and the number of the positive lymph nodes. So all these things are included. And this is an example where this is tumor bed, and the different sections are taken from A1 to A5. They have different cellularity. The overall cellularity is this. So this is just a chart showing 100%, 90% cellularity, 60% cellularity. So there is on the website, there is residual cancer burden calculator. So that if you feed the data, that is tumor bed area, which is 6 millimeter by 6 millimeter, the overall cellularity, cellularity, suppose 60%, DCS component is 10%, the number of positive lymph nodes is 0. And finally, we come to residual cancer burden score, and there is residual cancer burden class. So this is RCB class 2. This is a method developed by MD Anderson, and it helps in calculating the tumor burden. So it is an important prognostic factor. And so if it is RCB 0, then it is PCR, no invasive tumor. RCB1 is scattered residual disease. RCB2 is moderate tumor burden, and RCB3 is significant tumor burden. So basically, the residual cancer burden incorporates the tumor size, the tumor cellularity, the lymph node status. All these things are taken into account. Now, coming to the last part of my talk, I'll be briefly touching about the ER/PR and HER2 testing. The hormone, it is recommended that the hormone receptors and HER2 testing should be done on all primary invasive breast cancers, on recurrent and metastatic tumors. If the hormone receptors or HER2 receptors both are negative on the core, then repeat testing should be considered if the results are discordant as per histology. I'll come to that later. When do we actually write repeat testing is indicated? When multiple foci of tumor present, then the largest invasive focus should be tested. And if there are different histological grades or types, then you should test both the types, both the tumors basically. ASCO-CAP basically requires the recording of the pre-analytical and analytical variables because that will affect the ER/PR HER2 testing. So as I said, cold ischemia time, that should be less than 1 hour. That is important. The type of the fixative, that is 10% neutral buffer formalin. Whether decalcification was decalcified, that is whether you're looking at the metastasis to the bone. So that tissue will go for decalcification. That will affect the ER/PR HER2 testing. So ideally, one should prefer lymph node metastasis and avoid those tumors wherein it goes to the bone, because this decalcification hampers the ER/PR HER2 reporting. Status of the controls, primary antibody clone, what we used, and FDA status. So I'll just show you what normal control and what is tumor and what is internal control. So in most of the tissues, if you have resections, we try to take tumor with the normal ducts because this is the internal control. The normal ducts ideally should stain heterogeneous, weak to moderate heterogeneous staining should be there in all the normal breasts. And that indicates that the quality of the tissue and the processing of the entire test is validated. So one should use appropriate positive and negative controls, which will ensure quality assurance in IHC. Now, what are the reasons? Sometimes you would be receiving reports which give a false negative or a false negative result. So I would like to go in bit detail about why you get false negative results. Either there is some technical issues, if there is specimen is not handled properly, if there are crush or edge artifacts that interferes in our reporting, or if the test itself has failed. So that can be a cause for false negative. You may be getting 2-3 labs reports, which one is positive, one is negative. So how to find out the reason for the false reports? Cautery, as I said earlier, the thermal heat can cause damage to the tumor tissue, prolonged ischemia time, underfixation and overfixation, the type of the fixative. As I said, if it is an acidic fixative, then ER results are degraded, decalcification. So all these results in false negative results. Now coming to HER2 testing. In HER2, basically the normal ducts should be negative. And the tumor, if it is amplified, if it is positive, it will show a complete membranous fishnet-like appearance. This is how we are taught. It should be complete, strong, membranous like fishnet. It has overexpression has both prognostic and predictive factor. and these patients are eligible for anti-HER2 therapy. Now, even in HER2, there can be false negative results. The same culprits are this cold ischemia type. At times, in HER2, tumor heterogeneity can be a cause. So morphologically, we know if it is a high-grade tumor, if ER/PR is negative, if it's very high Ki-67, we morphologically we know that this should come, either it should be triple negative or it should be HER2 positive. Now, at times you get reports wherein one lab is calling it HER2 2+. We ask for FISH and somebody has called it HER2 positive. And then if you do FISH testing, it is not amplified. So I'll share with you a few of the reasons why we fumble or we have difficulty in picking up calling something 2+ or 3+. So basically, we're looking at protein expression on IHC. And in this biopsy, wherein the cells near this edge shown by arrow, there is pooling of this antibody. So this gives a false thing that this is stained positively, but actually it is not. This is an edge artifact. Sometimes instead of the membrane staining, the cytoplasm of the cell is stained. So that it becomes difficult whether it is membrane or whether there is cytoplasm, and then you end up calling this positive. And ideally, the normal duct should never be stained. So if there is staining of the normal duct, then one should downgrade the staining intensity of the tumor and report accordingly. And sometimes all the labs don't have pathologists who see the IHC slides in FISH testing, basically. So DCIs is another problem. One should interpret DCI should never be scored. It should all for HER2. Invasive tumor component should only be interpreted. So if the tumor has a lot of DCI, some pathologists can misinterpret as HER2 positive. So that is also an issue. This is as per CAP protocols, College of American Pathologists, we have the table wherein equivocal cases, we ask for FISH testing. And there are, of course, FISH is the gold standard, but there are also issues with the FISH testing when, especially when there is issue with the fixation. If the formalin, 10% neutral buffer formalin is not used, or there is prolonged fixation more than 1 week, those also result in failure of the FISH testing. And even so, the protein is affected in decalcification, so even the FISH results won't come. And the pathologist should be able to identify the invasive tumor and not and should also differentiate DCIs from the invasive in the FISH testing, because that DCIs will be may show gene amplification. So that is also an issue in the reporting aspect. These are other technical related failures for testing in FISH. And lastly, this is my slide wherein there are two different scenarios. One is low positive ER, which is by definition tumor which is 1 to 10% of the cells show ER staining are reported as low positive. And the new thing kid on the block is HER2 low. Breast cancers with HER2 IHC score 1 or HER2 score 2 plus, which is not amplified by FISH. These are eligible for HER2 targeted therapy, that is in the Destiny Breast 04 clinical trial. Trastuzumab deruxtecan combination is showing promising results in HER2 low cases. So this is the thing. So at the end, my take-home message is pre-analyticals is the shared responsibility of both the surgeon and the pathologist. The surgeon is the team leader and should lead from the front, especially in pre-analytics, regular monitoring and continuous education, especially if the specimens are sent outside. Fixation is the most crucial step. And final histopathological report essentials are, that is, tumor size, type, grade, extensive intraductal component, margins, nodes, number of nodes positive, the largest tumor deposit, extranodal extension, ERPR, HER2 testing. These are the essentials. And complete clinical and pathological responses are increasingly common. And these are my references. Thank you.
Thank you, Lira. I think it is very informative for me also, being a surgeon. Sometimes I think in initial days we used to fix with the formalin very late. So how important it is not only for the histopathological diagnosis, but also for the ARPR and HER2 also. And that's make a very, very big impact on our treatment. And especially when there is an era of low HER2. So this will probably change the next decade. So I'll hand over to Dr. Chetna Bhullar, madam. Madam, kindly comment about this lecture and your opinion also regarding this tissue.
Yeah. First of all, I would like to congratulate Lira on a very lucid and elaborate lecture. She almost
Madam is not audible.
So I just want to ask Lira, your experience, like when you get true cut biopsies, especially done for microcals. So do you find any challenges there?
Yeah, at times it is a bit difficult because when we process the core biopsies, we don't know well in advance that microcal is there, and we don't process it as decalcification and light decalcification and not done. So once we while cutting the sections and having slides, the calcified area around gets lost. Exactly.
Yeah. And many a times it is calcium oxalate crystals. So we don't see that bluish tinge. We have to see the polarized light. So that is one challenging area.
There's also one where we require radiological details from the surgeons the most. So
yeah. And
So
another, please,
yes, please, madam, please.
Yeah. And second challenging thing is sometimes in a bulky breast, which we received after neoadjuvant, we can't find the fiducial clip. It is very difficult to locate. So now generally we ask our radiology friends to just mark it by a suture, because once or twice we have to take the specimen to the radiology to get it, to locate that area. But since I'm working in an hospital setup, it is easier for me, but it must be very difficult in labs.
I work in a standalone lab, so I pick up the call and call the clinician surgeon. I do the WhatsApp calling, and then I show the sections of the breast specimen and try to see where exactly. So they have seen the specimen before surgery and after surgery. So that is.
I think today morning the specimen which I sent, it was 10 kilometers away from you actually.
Yeah.
So that happens. Okay. Any other thing from you, Dr. Chetna, madam?
Yeah, sometimes I want to let the surgeons know, sometimes when radical mastectomy is done, the axillary tail is removed separately.
Yes.
Then the main specimen. And if there is no radiology report and we don't know in which quadrant the tumor is, it's really difficult to orient the specimen. So maybe some mark can be made on the outer quadrant, upper outer quadrant, so that it is easier for us to orient.
Madam, actually, previously, when in my initial days, I used to remove this fat actually, the fat which is exactly over the deltobacterial groove. So what happens in that, if the patient surgery has been done first and followed by chemotherapy, then during the chemotherapy period, patient gains around 3 to 5 kg of weight. So that looks more bulkier, and the patient goes to some other doctor or somebody who's not trained in oncology, they will say that your breast is being still left. So patient will go for false, sonography, and somebody else will do sonography and they will put a needle into it. So that patient has to go for multiple false positive, the reports by sonography and all that. And they in their mind also, okay, there is
And
this
the
breast has been
anxiety.
left. Yes, and
Yeah.
anxiety also. So this was a
Yeah.
reason when I was in earlier days, I used to remove that fat, but now I'm being a little bit of
It's
a
not
severe
about
one.
you.
So I
Many a
stopped
times we get. Many a
yeah,
times we
now,
get. So,
yes,
yeah.
yes. And when your name was not that, people think that you have not, koi junior ne kaisa bhi kiya hoga, but now it is after all these years, now I stopped doing that. There is no point in removing that extra fat also. And you remove an exoretal, which is an upper outer quadrant. And sometimes because of the invent of this thoracoid, the transpositions, flaps and all that, we hardly do more dissection on lateral side. The lateral side of, because these are all perforated breast base flaps, they are very, very useful for us. And for sentinel node biopsy also, now the very small incision in axilla also will do sentinel node biopsy and all that thing. So that is one thing. But I just want to ask one question now. All the pathologists in Ahmedabad is very much expert in diagnosing DCIS on frozen section. So previously, after 10 years back, I used to be worried about that. But to everyone whom I worked personally, they all diagnose. Is that so difficult to diagnose DCIS on frozen section for a newcomer? The person who just started with the histopathological practice. Is it that difficult?
Actually, it is not.
Hmm.
But I think, yeah, experience works here also.
Even in my earlier days, I heard that DCIS cannot be diagnosed in frozen section. This is what the sentence I heard.
Like basically, when we, I usually have, we at lab, Unipath have doctors who do reporting fish testing, cytogenetics testing. So they usually come up and they usually have this query whether this is invasive carcinoma which has a DCIS-like pattern, or is this DCIS? So that problem is always there. So if it is invasive carcinoma with a DCIS-like pattern, they will include it in the fish reporting. But if it is DCIS, then they would exclude those areas for reporting fish testing. So it at times becomes, where, especially when we get blocks in everything, referral blocks from outside, when there is retraction artifacts and all these things playing to play, fixation changes, the tumor tissue looks smaller because of the pre-analytical variables. So at times, DCI, invasive tumor with a DCIS-like pattern and DCIS becomes difficult. So,
okay.
Ma'am is asking about frozens. In frozen sections
Frozen
alone.
section, DCIS in a
especially.
Yeah, especially.
Yeah.
So
So
even in that, if it has a DCIS, invasive tumor which has a DCIS-like pattern, it becomes a bit challenging.
Yeah.
Okay. We have Dr. Bhavana Mehta also with us. I made her panelist. Madam, are you there?
Yeah, I'm there. Hello.
Yes, hello, madam. Okay. We'll take your comment and after that we'll take a question and answer. So I think there are 3 to 4 questions from there.
Yeah.
Okay, madam.
There was an excellent presentation by Dr. Lira. Congratulations. Can you hear me?
Yes, we can hear you. Very well.
Regarding your last question on to diagnose DCIS on frozen section, I think the most challenging thing in diagnosing DCIS during frozen section, it is very difficult to cut the fresh fat for the technician. So we don't get good sections on frozen section. And that is why it is more challenging to diagnose DCIS. Invasive tumor is probably very easy with the experience. But because the fat tissue, which is not properly cut on frozen section, on cryo state, so it is difficult to diagnose DCIS. I hope Dr. Chetna and Dr. Lira will agree with me.
Yeah. Yes, definitely.
Yeah.
Because fat rolls on itself.
Yes.
Yeah.
Thank you so much, madam. And we have in a participant list, Dr. Ilesh Safi sir is there. Sir, can you hear me, please? Dr. Ilesh sir? We'll take his comment also. And Dr. Shabnam Bashir is also there. She's a surgical oncologist. We'll take her question. I mean, if she's there, she can unmute herself and she can comment about us. Ilesh bhai.
Hello, good evening, everyone.
Yeah, Shabnam.
Hi, it was an excellent talk, actually. And this is what, in fact, we at the smaller places keep on fighting with our staff always about. They have absolutely no clue what kind of harm does it do if you keep your stuff to shrivel down there without any solution, or so many people I've seen putting them straight away into the saline, and they don't even know what structural damage it would cause, or kind of pushing and trying to sandwich that tissue inside a small container. It's an everyday fight actually in the hospital. The moment I finish, I pack the stuff, and the first thing I do is that sit on their head and tell them that 10% formally in 10 times the volume. Just get it done right now in my presence, and that is never the last thing I would leave to anybody in the OT or anywhere else, because it can create and especially for the tumors that are as heterogeneous as breast, with the importance of each receptor. It is very, very important actually for us to educate every person in the operation theater, take special classes for the tissue handling, because it is as important as the surgery that we have done. The rest of the adjuvant treatment is going to be based on that. It was an excellent lecture. Thank you so much.
Thank you, Shabnam. Thank you so much. Ilyas sir. Ilyas sir, you have to unmute yourself and you can comment. Can you see any of the senior pathologists in the list? And by the time we'll take questions, there's somebody who asked a question like guide wire mastectomy for pathological calcification grossing. That is in the question and answer section. Lira, can you answer that question? You have to unmute yourself. You have to unmute yourself. You're unmuted.
Yeah. So basically, you have to see, you have this wire and you serially slice the specimen, and each of the slice you submit as sections, as labeling from medial to lateral aspect as ABCD, and submit the entire ductectomy or mastectomies, whatever the area wide, the guide wire area is sampled.
Okay.
That
And
serially slice it entirely.
that is, somebody asked, he's an anonymous attendee. If he's there, please ask the question directly also. He asked for the tips for the first year resident for histopathology.
For pathologist or for the surgeon, first year resident surgeon?
Not, but you answer on the behalf of pathologist. For first year surgeon, you just learn how to do surgery. That's it.
So best for us is to fixation is very crucial. So once you get the specimen, you bread loaf it and serially slice it. Keep cotton in between the slices, and if the the specimen what you receive is not properly fixed in a proper fixative, you transfer it into a bigger container wherein 10% neutral buffer formalin is used of our lab, of the lab which we have, and keep it overnight fixed, and then do the ER/PR HER2 status is most crucial for us. So that should be our main goal, apart from the tumor size and margin status. So next is, what is the ideal time for processing IHC markers after specimen reporting or biopsy reporting? So ideal time to process, if it is biopsy proven, reflex ER/PR HER2 is mandatory, or whether it is a metastatic site or recurrent tumor. So all these scenarios require ER/PR HER2 testing.
So as soon as you diagnose it is a positive malignancy,
you should do
ER/PR. So there is no ideal timing. Even if the patient comes out of 1 year also, are you able to do it from the same blocks? Or you require a fresh
if the patient is coming?
If patient comes after 1 year, somehow it comes later on, and then
We are from the blocks. If the quality of the blocks is preserved and everything, we are able to do ER/PR HER2 testing.
Okay. Uh,
On true cut biopsy, only small foci of atypical cells suspecting DCI is identified. How it should be reported when further IHC marker should we look for? So ideally, if you are suspecting DCIs and there is no invasive tumor, I presume that is the question. Then we should, if you're suspecting DCIs, then you should ideally do P63 and CK5/6. CK5/6 will be positive in hyperplasia, and it will be negative in DCIs, and P63 will highlight the myoepithelial cells in the DCIS. So, and ERPR strong positive in DCIS. In hyperplasia, it will show heterogeneous staining. So these are the markers I usually do.
Okay, this Smita Sharma has said that it is a very good topic and very practical information you provided. Lira, thank you for that. And
how harmful formalin is for the pathologist in day-to-day practice? Any suggestion?
Occupational hazards, occupational. Now you answer.
But then there, to check the formalin fuse, you have the meters available. So the that will keep in check the.
So
Give you
which
idea
organ
about
gets affected more? It's eyes, skin, or what? Because the eyes and I think the face is more first.
Yeah, that
to be
then
exposed.
shows a lot of burning.
So what is your problem? Maybe after 15 years of your practice, in a working like Unipath,
I'm standing in front of you without any trouble.
So I mean, which part? I mean, is there any problem to eyes and face, skin? I mean, I can't see much
that
of.
Causes bit of burning if the amount of formalin fuse. But we have labs which have open, exhaust and open windows, so the fume goes away, and we have the exhaust fans also, so which keep the environment room ambient, with less formalin damage. What are the changes that a biopsy report of chronic mastitis to be, and in what are the chances that a biopsy report of chronic mastitis to be invasive cancer in lumpectomy?
Okay.
So if it is, sometimes if you get non-guided biopsies, if you get USG guided, at least the radiologist is sure that is the lesion. If the tumor size is very small and there is surrounding inflammation, the biopsy might have hit the surrounding breast and not the small foci of tumor. So that can lead to negative biopsy report and a positive tumor on lumpectomy excision specimen. Chances are few, but at times such scenarios do happen. But that can.
I think the malignancy having a secondary infection. I think chronic mastitis, what I see moreover, I should not miss the autoimmune mastitis or granulomatous mastitis. This is one is in my concern. And second is a periductal mastitis. This is what we are thinking about. Because start with the lactation mastitis, acute lactational mastitis or abscess, followed by chronic mastitis. The chronic mastitis has now a lot of other types also. Maybe the hidden malignancy will be there. Then in case, I think you have to go for the excision biopsy rather than just relying on the cut biopsy. This is what I presume in this question. K67 ideal time to send to the
lab immediately or routine. So basically you do Ki-67 especially when you're planning to give not going to do molecular testing. It is just like a surrogate marker, and especially when you feel the nodes are maybe clinically negative, you do ERPR, HER2 and Ki-67. Usually we get in the same go request by the clinicians.
Okay, does it make any difference in the days if they pass, it goes on, or I mean, any time period you should do, or generally we order with the ERPR HER2 new?
HER2 only.
Yes, yes. Because Ki-67, if it is a lace, it has got a very much important role in planning that can assist or the oncotype DX test for which we want to send the patients, whether we want to avoid chemotherapy or not, whether it is a low score disease or the high score. where I presume it should be useful. And second thing, Ki-67 is useful for the patient to whom you are going to give a new urgent hormonal treatment in a fragile elderly ERPR positive patient, where you don't want to give chemotherapy, you want to downstage the tumor. So there only Ki-67 has got a role in baseline investigation. If it is going down, then you think that your patient is responding to hormonal treatment. This is what it is written in NCCN guidelines. So I think the 4 markers should be done together, all together.
Especially as per Ki-67 working group, there is some working group wherein they have said that ERPR are robust marker, but Ki-67 is also affected more by the pre-analytical variables.
Many. If you take in the center of a tumor, if you take from the periphery of the tumor, I read one article on the Ki-67. I was so, how difficult it is for the pathologist to diagnose for Ki-67.
We have to count 1,000 cells,
Our
and that too in the basic front of the tumor, necrosis should be avoided. So all those things.
और ये fixative का slide देख के तो मुझे लगता है कि hope our patient should not be miss ERPR positivity in too early fixative patients. अगर ये corner से लिया तो positive आएगा, वो corner से लिया तो negative आएगा. And you think about the HER2/neu positivity. If the patient gets HER2/neu positive, he or she will be getting trastuzumab. If she is taking pertuzumab or Phesgo, the treatment is costing 2.25. Multiplied by 17 injection, you count about it is 35 to 40 lakhs rupees of the 1 year of treatment. And if you give that report a negative, you confirm that you have saved that money, those money actually. And the low HER2/neu negative, which is a new thing, and probably it will going to change the entire era of just like a HER2/neu positivity and introduction of the trastuzumab. It is going to change because the trastuzumab restriction is extremely very good treatment option for low HER2/neu positive patients. We have one more question from Dr. Vinod Dakad. He's a surgical oncologist. Vinod, if you are there, you please unmute yourself and ask the question directly. Can you do that, Dr. Vinod? So he asked, what is the significance of plasmatoid cells?
Plasmacytoid cells.
Dr. Vinod is there. You please ask the question.
Yes, ma'am. Actually, confusion is, ma'am, sometimes the patient present with young ladies, they present with mastalgia. And whenever we go for investigation, we find some nodule or some benign lesions. And if it is suspected, we biopsy it. Then sometimes we identify some chronic inflammatory cells in that. And some ductal hyperplasia like picture. So what the significance of plasmatoid cells, plasma-like cells in that? Because the patient is complaining of pain and she's not having acute inflammation, so as to we give some treatment for that. But for chronic inflammation, the plasma-like cell, what is the significance for that in the breast biopsy?
In any chronic inflammatory condition, we usually see lymphocytes and the plasma cells. So that will come in any of the chronic inflammatory condition. So if a chronic mastitis patient will also show dense lymphocytes and plasma cells around the ductules. So that may probably be maybe the cause of mastalgia or pain or because of chronic mastitis. Otherwise,
and ma'am, how does that this ductal hyperplasia looks in the slides? How we can differentiate
ductal hyperplasia from ductal hyperplasia from chronic mastitis?
No, ma'am. Simple ductal hyperplasia versus atypical. Yes.
From ductal hyperplasia. So yes, suppose I usually give the example of suppose this is the duct and there is streaming of this bilayer, that is one of the luminal cells and other is the abdominal cells or the myoepithelial cells. So if the apart from the two bilayered ducts, there is proliferation of the ductal epithelial cells inside the lumen, and they try to have a streaming like effect of proliferation. This is usually seen in ductal hyperplasia. But once they start becoming monotonous, there is nuclear enlargement, and they try to, cover the entire lumen and try to form Roman bridges, tight bridges, which we use the word rigid bridges like the Roman bridges, cribriform pattern. Then if it is 2 millimeter in size, it is atypical ductal, 3 millimeter in size, less than 3 millimeter, or it is called atypical ductal hyperplasia. And if it is more than 3 millimeter or more than 2 duct involvement, according to different criteria, so then it becomes DC, goes towards DCIS. So that is how we
So how do you see plasma cell mastitis? Do you see very often? Lira?
Like in any chronic inflammatory mastitis, it comes as a package along with lymphocytes. Plasma cells come along with the lymphocytes.
No, I mean, incidence is very much, or it is very, very rare?
We see quite a bit, but not as a true cut biopsy. We usually get it in lumpectomy specimens sometimes.
Okay. So, Madam, Chetna Madam have seen is
less often in a true cut biopsy, less often, because the true cut biopsy is usually the surgeon is doing to hit the tumor. So not tumor.
Diagnose on true cut biopsy, or you need a lumpectomy specimen to diagnose the plasma cell mastitis?
Lumpectomy should be done, ma'am, because true cut biopsy will not be representative of the lesion.
So the problem is with the mastitis nowadays, there are a lot of type of mastitis, and when patient comes with many of the files and many antibiotics, you think that you are landing up with either autoimmune or now you name it is called the plasma cell mastitis. So I think the lumpectomy is a better option to diagnose plasma cell mastitis. That is what you want to tell.
Yeah, definitely.
Thank you. The last question is, the Dr. Atul Domadia, if you are there, you ask the question directly. Dr. Atul. How to interpret the partial staining in HER? Dr. Atul, yes. You have to unmute yourself, Dr. Atul. Lira, your answer for this?
Okay, so basically partial HER2 staining, if it is faint, barely perceptible, it is a score 1, and no staining is 0. +2 should be complete staining, weak to moderate complete staining, membranous staining is score 2, and if it is complete staining, strong membranous, more than 10%, it is considered score 3, positive. So partial staining would basically go into low HER2 or score 1 staining.
Okay.
That is how we...
So the last question we have today is how artificial intelligence will help pathologists in reporting?
So basically, especially those which are AI based, that is algorithm based, like ERPR, HER2 testing, KI67, these things can be, you can train the AIs, and you can have algorithms, and they are at places being done, and ERPR, HER2 can be reported. So AI can improve our efficiency and take bit of our burden by calculating the ERPR, accurate ERPR HER2 KI67 basically, and also pick up small foci of metastatic tumors in the lymph nodes. Sometimes it becomes difficult, but if you train the AI and they have these algorithms, they can pick up the lymph node mets.
Dr. Pramila has raised the hand. Madam, you are allowed to talk. Please unmute yourself.
Hello.
Yes, madam.
See, I'm professor in Goa Medical College, and I report histopathology of I have reported cases of cystic neutrophilic granulomatous mastitis, and our surgeon has been very good in treating these, with long-term antibiotics like cyclin, and these patients have been wrongly diagnosed as tuberculous mastitis, and they've been unnecessarily put on 9 months treatment of AKT, etc. So this entity, I feel, should be aware among the pathologists. I've got at least 2-3 cases, and I published them also. 2-3 cases of cystic neutrophilic granulomatous, and they've responded beautifully. They've come for FNEC earlier with a lot of these, so to say, papules oozing past this, that, and all. And you see on microscopy, typically these suppurative granulomas around a fat vacuole. If you pick them up and get back to your surgeon and tell them that this is this entity, and they respond beautifully. That's all what I wanted to get back to the pathologists.
Yeah,
Yes.
I mean, in the breast practice, breast oncology practice, one of the most fearful thing is the mastitis. And when you end up doing all this, the big name of mastitis, AKT doesn't work much in autoimmune cases and all that. You need to give a steroid, or either sometimes you ended up in giving methotrexate also. And
Yeah, but
yes,
I'm sorry. If you diagnose this condition, I mean, on the histopathology, around these fat vacuoles and all, and I have seen patients with in collaboration with my surgeon in Goa Medical College. We have treated them beautifully. Some months of treatment of this doxycycline plus, I think they put another cephalosporin, etc. And they have responded really beautifully well. And we have avoided AKT in these patients in private, and they have been misdiagnosed as tuberculous mastitis and all sorts of things, and they've really landed up in good hands with our surgeon with this diagnosis. That's all I wanted to put forth, to make aware this entity.
It's really very good question. We will do one lecture on that mastitis also.
Yes.
For everyone. And I think it is a lengthy treatment. Patients sometimes recover after 3 months, 6 months, or 9 months. One of my patients recovered after 1 year. And when patient comes to us, they already had taken AKT for 3 to 6 months also. And
Yes.
Even sometimes what we do when we give a treatment, it get necrotized and liquefied. So we do serial aspiration. We do serial aspiration of that, because every time you cannot take the patient to theater and do IND and all that thing. So serial sonography monthly, and if it is a liquefied, aspirate there only. So this is how you increase the area of mastitis. So
exactly.
Really very good point, madam, and that is actually they mimic like a malignancy. The patient is always
yes. Thank you.
So, anybody wants to ask the question, they can raise the hand, and we will take question. Many of the people there, the person asked me in chat box also in a personal message that you will get this is a wonderful lecture. If you want a recording of it, we have recorded this thing. I'll put in that group, the close group. I'll put this recording. It will be seen on my website also, but it will take around 2 to 3 days of a time. So we'll shortly get recording. Thank you so much, Lira. Very to see this.
Thank you for inviting me.
Yeah, thank you, Dr. Chetna, madam.
Thank you, ma'am. Thank you.
This webinar after so long, after 3 to 6 months, 3 to 4 months, and still I got almost 73 participants were there into this webinar. Thank you so much. Thank you, Ketan bhai.
Okay, bye, ma'am.
Thank you, ma'am. Thank you, everyone.
Thank you, Ketan bhai, Saurabh bhai. Thank you, and thank you, Rajat bhai. Entire Zydus team. Actually, I put a special slide for all of you to thank, because I never thanked you publicly, but somehow this slide didn't work today.
Thank you, ma'am. Thank you. Thank you. That's always our pleasure, ma'am.
Especially took a permission for this webinar. Otherwise, the routine link, if the speaker is speaking, the rest of the other people make a noise. So this is a special kind of a link where the only when one person is giving a lecture, the others are already on. So thank you so much, Ketan.
Thank you.
Thank you.
Good night.
Bye.